Dear colleagues, clinical case that I prepared for you today. The next one, this patient was referred to me by his dentist. This endodontic treatment was done many years ago. No pain, no discomfort, just translucent area. On my examination, percussion negative, palpation negative, no pocket, no sinus tract, and we can see some radiolucent area without exit border. Okay, and we can see that it's go to tooth number 37, and of course I examined also the 237, percussion minus, palpation minus, no pocket, no sinus tract, call test positive. Because I see no clear border, I referred patient to CBCT, and on CBCT we can see huge hypodense area from mesial root of 36 to mesial root 37. We can see that this hypodense area does not connect to mandibular canal and does not penetrate buccal and palatal cortical bone. When I see this huge lesion, I want to put here differential diagnosis. And I want to remind you that when you put things in list of differential diagnosis, it's very important. It's not a random list. We want to put in the first one the most possible one. It will influence our clinical decision. In the first place, I put here is asymptomatic apical periodontitis, and after I put odontogenic keratocyst, ameloblastoma, and finally I put central giant cell granuloma. I explain everything to patient. I explain that I will start with retreatment. And after 6 months, after reevaluation, we will decide if it's enough or if we will go to surgery with biopsy. Very important. Okay, and I started my retreatment, and during retreatment, I changed the working lengths, and I wired the canal to number 30 with irrigation of NSL and HEDP, my continuous chelation with agitation by SF system, and with obturation with gutta percha and a BGM root canal sealer. I put my temporal filling, and I recommend to dentists to put post-endodontic restoration and temporary crown. I did it during one visit because it was dry canal, no signs of active inflammation, and the size of lesion does not influence our decision about 1 or 2 visit treatment. Okay, but after 6 months, what I see the same temporary filling. It's so important for us to do high quality temporary filling, double fill temporary filling, because we never know what patient will do or his dentist will do with our work. It's very important. Also, I think it's important for dentists that work with referral dentists that they will use BGM root canal sealer because it's epoxy sealer with macromolecule that can prevent biofilm ingrowth. Okay, what about reevaluation? On the first view, when I see the diagnostic X-ray, and after 6 months, I can say, wow, great healing. But just a moment, please see the final one that I did during one visit. I have healing also here now. No chance of healing for one visit endodontics the same day. I understand that it is a matter of the angle of X-ray. And I understand in this specific case, I want to see CBCT for evaluation. Again, I'm always go with a LARA principle, as low as reasonably achievable. But in this specific case, I must refer patient to CBCT to be on the safe side, to be sure that everything is going well. And I did it, and you see a good healing process, a new bone, new trabecles. Again, you can compare CBCT before starting of treatment and CBCT after 6 months. And of course, in this point, I wrote in the file of patient that we have healing process, okay? And I asked his dentist to finish post-endodontic restoration and to put final crown. Of course, I will continue my follow-up, and I will update you with the final result. Have a nice day.